Good morning. Welcome to another edition of McMaster Perspective, and I have great pleasure of introducing Dr. Sean Wharton. The impetus to this interview and presentation was what caught my eye in New England Journal of Medicine, which between August of 2025 and December, I've seen a name of Sean Wharton every month. It was quite surprising. We are both in Hamilton. I'm aware of most of the research going on here, but I have not known about the extent of your accomplishments. Sean, we know each other from the time I was a mature attending and you were junior resident. Please tell me, how did you go from being a resident in internal medicine outside the mainstream of research in Hamilton to this world prominence in obesity research?
Thank you, Roman. I must say that my time at McMaster, and I'm still at McMaster, but I mean my time during my residency was wonderful. Those were really great days. You were part of those days. So thank you, Roman, for being part of that. So how did this happen? And it really has been somewhat of a meteoric rise, but it was planned. I really did know what I wanted. So as an immigrant, I was born in London, England, but I'm from British Guyana. I'm from the West Indies. So we came to Canada as immigrants, as you, Roman, from Poland, where and multiple other people. And being like coming at around age 7 or 8, I wanted to. There was a need as the first person in my family to reach this level of prominence. My dad is a physiotherapist. My mother is a professor. So the academia was always there. But I wanted a combination of being able to have entrepreneurship and academia at the same time. I wanted to build my own business, a medical business, but I also wanted to be an academic researcher. How was I going to do both? I thought, can I do both? I said, of course I can. If I set my mind to it, I can do it. And so I finished my residency at Mac, and then I opened up my own clinic. And so it was a community-based internal medicine clinic. I really believe that internists could live outside of the hospital setting. Not an easy thing to do, but I wanted to actually build it. And so I worked very hard working ICU shifts up in Northern Ontario and internal medicine shifts to make enough money to come back to put money into my own business and try to start it up. It wasn't easy. And I did that knowing that I wanted to do obesity medicine. Obesity medicine came to me because I saw a physician, Arya Sharma, doing a presentation on obesity medicine. And it wasn't just about the science, which was brilliant. The neurobiological science that nobody understood, that came from the gut and went up to the brain and spoke to the brain in different ways. But it was also about the social aspect, the psychological aspect, the social determinants of health. I was working in the field of trying to understand why Black people had a worse time with high blood pressure and multiple other medical conditions. It's not that they have more of these medical conditions, that they're treated worse, and that there's a social dynamic connected to it. And this spoke to me in obesity medicine. Obesity medicine deals with bias, stigma, and discrimination. As a Black man, I deal with prejudice, stereotype, and racism. Those are the exact same words: bias, stigma, and discrimination, prejudice, stereotype, and racism. Same type of concepts. So obesity medicine spoke to me as a place where I belonged, a place that had great research, that was just starting out, had people who were discriminated against, had nowhere to go, felt ashamed, felt blamed, and I wanted to build something that made an accessible space for them. And that wasn't inside the hospital. I tried to do it in the hospital and with the research teams there. It didn't belong there. Wrong space. It belongs outside in the community. And that's where I built it. And that's why the research happened there. So it's been a great ride, and I'm pretty happy about it.
So your ability to start participating in the clinical trials stem from the fact that you were in the community and you were working with those people. Is that correct?
Yes, it is. It is correct. And to some degree, what I should do is, you know what I'm going to? I'm going to share my screen, and I'm going to share a presentation, because there's a part of this little presentation I did for the Hamilton Academy here. I'm going to show you. Can see my screen now, right?
Yes.
Okay, great. What I want to show you is this. So that's my wife. She's a family doctor living in Toronto, and that is baby James. Baby James was born September of 2020. And the guidelines are right next to me. The guidelines are right there as well. The guidelines were published September of 2020. They're the same age. And essentially, it took 72 authors in 3.5 years to produce these Canadian obesity guidelines. And they've been seen around the world. It was a watershed moment. The obesity guidelines were about bias, stigma, and discrimination and access to care. We wrote a guideline that was not just about science and pharmacotherapy and the surgical options. We said, you, the doctors, you, the healthcare providers, are misbehaving. You're not taking care of patients the right way. You're not giving them access to care. You can do better. It was about bias, stigma, and discrimination. And that's why I built the clinic. So I have this clinic. I established the clinic 2 years after finishing my residency. Established 2008. I finished my residency in 2006. And the idea was that patients didn't have to pay for their weight management care because they deserved care. So the access to care was the really, really important part. That should be 750,000 patients.
Yeah, no, that's what I was looking, 7.5 million.
Like, what is that? Yeah, that was a clear
No, that's
error.
okay. Don't worry
that's
about
very funny. So you can see that we've seen about 750,000 patients, and most of them women. But the big deal about this is that they're referred by family doctors, and they get to come to the clinic without having to pay for care. Now, you don't pay for care for a broken leg and for multiple other things. So why was this such a big deal to me? Because people were paying for care for obesity management because they weren't believed that they had a disease state. People just told them to eat less and exercise more and go to a paid for clinic and do your own thing, instead of believing that there was something happening and this was part of the discrimination. They're discriminated against. So this clinic makes no money because it's government funded. So it's not a profitable place. It's a place where you just get enough of the care that makes it possible to keep going and to do the right thing. I strongly felt I needed to do the right thing, and I couldn't make this in the hospital. It was impossible. And the reason why, and I do clinical trials. Clinical trials are frequently phase 2 and phase 3 clinical trials. I do academic work too at McMaster at the University of Toronto. I'm a University of Toronto person also. But these clinical trials are the ones that frequently forward new medicines. And as a result of running a phase 2 and phase 3 clinical trial practice, we got to try new medications. So that's kind of the details of the journey. The journey was I was upset about the discrimination and the lack of access to care for the Indigenous population, for Black women, for new immigrants who were living with obesity, living with the struggles, who were not believed. I wanted to build a place for them, and also build a place that had clinical trial medicine connected to it. So that's kind of my story.
That's quite a journey, and maybe some roadmap for people who would like to do similar things, not necessarily in the same clinical areas, but maybe even in the same clinical areas in other places.
Yes.
Well, that's quite something. So let's go now back to obesity. You obviously chose it because there was plenty of people who felt overweight. Could we talk about how prevalent it is? why some people get obese and not the others. This is probably the most annoying question when you see your friend eating twice as much as you do. And what is the physiology of obesity? Maybe you could spend some time talking about that.
Yeah, Roman, it's a great question. And you know what? In this field, we're very humbled to try to understand why some people have a lot of weight and other people don't, or what obesity is. I don't know. I don't really know what obesity is. And I'm one of the lead worldwide researchers. So the more that we start to find out about it, the more we find that we have these roadblocks and unanswered questions. The smartest scientists are still working on it and haven't come up with the best reasons for it. These are benchtop scientists, particularly in the genetics field. So the primary thing that we've discovered is that it is genetic in origin. So if you have two parents living with polygenic obesity, the chance that the child of theirs will live with obesity is almost 100%. If 100%, even if that child goes to live with Gwyneth Paltrow and eats really healthy food and exercises every day, they'll still be living with obesity. It is genetic, primarily a genetic condition. So people frequently, you would say then, well, where was it 200 years ago? Because our genes haven't changed in hundreds of years, and they haven't changed in hundreds of years. What pulls the trigger of that genetic predisposition is the environmental changes. And what are the environmental changes? Because people blame specific things like McDonald's and Coca-Cola. They aren't really all that much to blame. What's more so to blame is things like air conditioning, women's rights, being able to have a child at age 35 versus 18. If you have a child at 18, the chance that that child will be living with obesity is way lower than if you have a child at age 35. If you are on antidepressant medications, that causes an increase in weight and causes some maternal challenges. Every antibiotic, every increase in, and every medicine that makes you live longer increases the risk of the chance that obesity will be another major challenge, because you don't have to work as hard. Anything that makes us not work as hard, from our cell phones to the TVs to as I said, heating in our house, air conditioning in our house, all that changed. Those are the environmental changes that led to the genetic predisposition to be uncovered, not just some Coca-Cola every once in a while and all of those type of things. If we get rid of every fast food place and all of Coke, there'll still be obesity, and that is a fact. So it is genetic. And the question is what are these genes acting on then? What are the hormones? Because seemingly we've got some treatment options, and the question of which hormones are being activated comes when we take a look at some of. I'm going to take a look at this presentation again here. It's right here. It's all in the brain. And it's in the hypothalamic area of the brain and the mesolimbic area of the brain. We found a bunch of hormones. We didn't find these hormones 30, 50, 60 years ago. These hormones were only, the first one that was really found was leptin. And that was 1993. It was like yesterday, it feels like. These are all new to us, and we've understood some of them, but we didn't understand the degree to which they control weight. And what they all try to do is keep your weight up. They all try to keep your weight up as much as they possibly can, because God, whoever she is, believes is that if you're 100 kilos and you want to be 75, she wants you at 100 kilos. Because there's going to be a famine, there's going to be a problem, there's going to be some issue. So ghrelin is the main bad hormone, quote unquote. It causes you to be hungry, and all the other ones are good hormones. They cause you to the leptin, PYY, the ones in the hypothalamus that I'm talking about there. They help to stop eating. So, but I just told you that all these hormones cause you to gain weight. What happens is that as soon as you decide you want to have less calories than you did yesterday, your ghrelin goes up and your good hormones go down. So there's always a counter regulatory mechanism to stop you from losing weight. Good hormones go down, bad hormones go up. As a result of discovering these hormone systems, we've been able to figure out maybe we could block the hormones that push the weight up and elevate the hormones that help the weight to come down in the face of our own system decreasing the good hormones and increasing the actual bad hormones. So that's the essence of the therapeutic interventions that have been discovered over the past 5 to 10 years. It's brand new.
Sean, so I'm clear. The ghrelin, which is in the stomach, is the hunger hormone. It goes up. But what makes it goes up? Our willingness to eat? Our hunger, or does it cause hunger? What is the cause and what is the effect? Because you labeled all of them, even those leptin, PYY, GLP-1 as bad one here, but bad in behavior because they go down when we want to eat.
Right.
What's the chicken? What's the egg?
That is the multi-million-dollar question, Leptin. We don't know. I don't remember. I started this presentation by saying that I don't understand obesity. I don't know. And the brilliant scientists, they had this huge consensus data, and they came up with almost nothing because we just don't know what starts it. Like why is somebody who in the same environment of all the things that we have today, why is that person 120 kilos and another person is 80 kilos? How's that possible? And where's their extra ghrelin coming from? Why did they get extra ghrelin and somebody else didn't? So
the ghrelin is working on one axis to make us eat more, and leptin, PPY, GLP, CCK, and amylin, if elevated or if used as agonists in terms of drugs, they will decrease the need for food. Effectively, will decrease what we eat, will increase our satiety, will decrease our hunger. Correct?
That's absolutely right. That is correct.
Well,
and the whole trick was finding a ghrelin blocker, or which we haven't really found yet. They're still working on aspects of that, and finding congeners of all of those things: the leptin, PYY, GLP-1, CCK. The problem is it's hard to make one that doesn't cause other problems within the body. Goes to different areas, causes different things. Don't forget, this is a polygenetic component of weight management. Weight management is hundreds of genes, hundreds of hormones. And if you start messing with things, you mess with a lot of other things too. So the holy grail recently has been GLP-1. Seemingly, it's the most benignish hormone to come out and doesn't cause a whole lot of other problems. You haven't figured out leptin.
Before we go there, and I'm pretty sure we go there because that's a major part of your research. There is this other part here: dopamine, opioid, cannabinoids. What's that about?
Oh, that part's beautiful. That's my favorite part. Although most of our drugs lie within the hypothalamic area, the mesolimbic part of the brain is the hedonic part of the brain. And the hedonic part of the brain was there before we were even human beings, because it helps for the survival of species. It's excess. You got to do excess things to survive as a species. The two things you need to do excessively is eat and have sex. Eat and have sex. And God, whoever God is, wasn't going to leave that to soft hormones like ghrelin and leptin and PYY. It's going to be dopamine, opioid, and the cannabinoid receptors, intense hormones. And what happens is that center of our brain is always working. It never shuts off. Never shuts off. It only shuts off when the executive lobe tells it to calm down. I'm in a meeting. I'm doing a presentation. I don't need to think about this at this time because I'm working. I'm doing something else. So the executive lobe does that very well when it's rested. right? It's had lots of oxygen. It sends a message to the mesolimbic system and says, stop thinking about sex and eating. Now, the executive lobe gets tired at the end of the day. And it gets tired when it gets stressed because it's being used way too much and it's been abused or there's been other issues. So when do people excessively eat or have more sex than normal? It's not at 10 o'clock in the morning. It's in the evening. That's when the excess eating, the excess hedonic components end up happening because the executive lobe shuts down and lets that hedonic lobe that's always active come to life. Now, if you happen to have too many genes in this area that promote more of this, you have more difficulty in maintaining a proper balance for today's world. And the new medications and bariatric surgery tends to help that a bit, and also CBT. So CBT makes that executive lobe stronger, right? It says to the executive. It says to the executive lobe, yeah, that's right. Cognitive behavioral therapy says, wake up, executive lobe. It's 10 o'clock at night. At 10 o'clock at night is when I start to fail. And dopamine and opioid starts to make the mesolimbic system work way better. Wait a minute, I'm bright, I'm capable. I did cognitive behavioral therapy lessons, and now I'm going to wake myself up. I'm cognizant that I overeat in the evening or I do bad things in the evening. I'm cognizant of it. My behavior is those specific things. Let me do a different behavior. I'll go for a walk. I'll read a book that wakes up my executive lobe to counteract the mesolimbic system. That's the therapy, CBT. So you can see that we didn't understand this 20, 50, 60 years ago. This is new. So when I say we don't understand obesity, we're like children learning about this fascinating neuroscience area of the brain and how it affects fat cells in the gut. I did not think that I would be in neuroscience when I went through my residency, Roman. That was not my strength. But here I am working in the neuroscience field and trying to make it explainable to most people.
So for some things, if we're talking about cannabinoids and opioids, they would stimulate the mesolimbic reward system, right?
Yes.
Or they are the reward.
They are the reward system in a sense that these hormones drive wanting and hunting, right? And so if you're hunting for a partner, okay. That's dopamine. Dopamine causes the hunt. People go out to a nightclub and they're hunting around, and and that's an intense hormone to hunt. If you have too much of that, you're hunting for food, hunting. And then opioid is the liking part. You find that partner, you find that delicious cheesecake, and you ingest it, and you're really liking it. Now, what happens is you can get imbalances in those systems where you need more and more of the thing that you've hunted to get the opioid response. Whereas somebody who's thin, just naturally thin, they take in a little bit of cheesecake and their opioid system's fine. They get lots of it. Somebody who's living with obesity takes in that cheesecake, no opioid, more cheesecake. Finally, so it's like opioid happens.
Endogenous opioid receptors, which, if stimulated, they will bring a feeling of satisfaction. I mean, on a different level, I know that people who run, for example, marathon, had a lot of opioid stimulation by the end of it and are ecstatic and
yes,
deliated effectively. Okay. Well, listen, I believe I understand a little bit more about all this to whatever, and the science seems in the end fairly straightforward.
And one part of the science that I think we need to explain, though, is that, do you see how I have that arrow going from the executive lobe over to the hypothalamus, mesolimbic system? Many people living with obesity, that's a highway. The highway that goes to, say, shut down your cravings works very well in thin people. It doesn't work so well in people living with obesity. They just, for some reason, genetically, that highway is not very smooth. As a result, surgery and some of these medications smoothen out this highway system so the executive lobe can be active. And that's why we think it can work in Alzheimer's, because the limbic system and the hippocampal system that stores our memories. So my father is living with Alzheimer's. His memories are in the limbic system and in the hippocampal area. He just can't get them because his highway is broken. So if we could smoothen the highways, and some of these medications seem to be doing this, GLP-1 and other hormone modulators. You can grab those memories back from the limbic and the hippocampal area so that Alzheimer's can be cured. So because we're always wondering, how is this obesity and the Alzheimer's drugs, how is they're all connected? It's because of this highway system that can be smoothened out, and it works in obesity too.
Looks like you could open another clinic, Sean. But let's finish this part